This morning, what I thought we would do is really try to focus in, because we have a short period of time, on the questions that were posed to me that you all might want to hear about. And so these were questions like, how do we prepare for surgery? Do we do a tape and screen? Do we do a cross match? And this is a pretty hot topic for us right now because it's a common utilization metric, and we are working to get a solid method in place to be able to track that and keep providers informed as to what their metrics are looking like so that we can track this. So we've been actively talking about this for a while we're building toward that. What blood products are available? So I'd like to hear from you when we get to this topic is exactly what you're asking. But one of the aspects I can think of is just what's available on site. And recommendations for transfusion support in acute blood loss and transfusion support for patients with coagulopathies. So we'll try to hit on those. And so my objectives for the day are to certainly answer those questions, and I'd like to weave in some other topics that come up in relation to that. One is transfusion consent, which is another hot topic in our lives in the last few months. Use of our order set, patients with special considerations, in particular people who need special types of blood products. And we only have 30 minutes, so let's get running. So this slide has a lot of information on it, but I think that it ties together a lot of things that people don't always remember go together. So, how do you prepare for surgery? The way you prepare for surgery is to think about how likely is it that I'm going to need a transfusion, or this patient is going to need a transfusion. So if it's very unlikely, basically you don't need to get consent from the patient because you're not planning on needing this. You don't need to do a type and screen. You don't need to do a cross match. You're not going to be concerned about how long it takes blood to get to the OR. And we're not talking about a patient with an antibody because we didn't even look, right? So that's pretty straightforward. If we say there's a low risk, but it's possible, how do you quantify that? Probably something in the 1% to 5% range or less than 5%. But we think it's possible, so we should definitely be talking to our patient about that, right? That they'd want to know if they were going to get a transfusion. So we think we should be getting transfusion consent, and we would do a type and screen, but we wouldn't want to cross-match units unless the patient has an antibody. Okay, so this speaks to how important that antibody screen is. If you come up with a positive antibody screen, really all bets are off. It's going to take at least one more hour just to figure out what the antibody is. And then it's going to take a bunch more time, potentially, to get in matched units. If the antibody is easy to match for, they're here on site. If it's hard to match for, they're not on site. We have to call to a reference lab or a rare donor registry to get that blood. So, and we wouldn't cross-match if there's a low risk of bleeding, because if we have no antibodies and a low risk of bleeding, we know we can cross-match blood very quickly. We use what's called an electronic cross-match, and really the longest thing about that is printing the piece of paper. So it's truly, you're an OPOS patient with no antibodies, an OPOS unit off the shelf is considered compatible with you. We use barcode scanning for the computer to make all that logical association, and there are certain criteria that have to be met in order to do that. But once it's done, it's just a hit print. We say, yes, we accept that computer match, and you have to wait for the paperwork to come out. And then we tube it to the OR. So if that's where you are, we're only talking a few minutes to get blood under those circumstances. If your patient has antibodies, and this is true whether they're an OR patient, neurosurgery or not, at least at Swedish, we maintain this practice of reflexively getting in 2 units of matched red blood cells. So you don't really even have to order it. It just happens. It's like a medical policy. And so I would say you don't have to act on a patient like that. It's when you get into this high-risk category where you think transfusion is likely. And then I would say this very high-risk category, which is where not only is transfusion likely, but you have a significant concern that you're going to need blood early and fast in the case. And the difference between those is that if you think you're going to need blood early and quickly, I would suggest that you do cross-match those red cells and that they live in the OR refrigerator, so they're right at your fingertips, right? As opposed to somebody who you just think, this is probably going to happen at some point in the case, and we can get the blood in a few minutes when we need it. in which case you don't even necessarily have to cross-match or have the blood in the OR fridge. And so the important part of that in our day-to-day practice is that in actuality, we see a fair number of orders that are stat red blood cells for the OR to sit in the OR refrigerator for a case that's happening sometime today. And so most of those units don't get used, in fact, because they're low-risk cases. And so that's a place where we're trying to refine our practice. Not only not cross-matching the units, but not ordering them stat, for instance, where somebody's dropping all the work for all the other patients in order to do this cross-match for a patient with a low likelihood. So that's something we're trying to tackle here at Swedish. It's a common problem across the country, and we all try to keep everybody in line so that we're not doing excessive, crazy work that we just have to undo a few hours later. If your patient has an antibody and they're in this highly likely need to be transfused, then I think we should talk. And this is where the value of a pre-op type and screen really stands out. Because now you're not finding out on the morning of surgery when you've got a 7 o'clock case that your patient has an antibody, and like I said, all that time becomes an open-ended time period, and your day is botched, the OR is screwed up, everything falls apart from there. So it's great to get your pre-op type and screen as a pre-admission, and I know that many of our patients don't actually come for a physical pre-admission appointment, but this is one of the benefits of an appointment like that, is to get that pre-op type and screen done so you don't have any surprises on the day of surgery. And so just to point out here, this antibody screen is this critical result. About 5% of patients will have a positive screen. In the general population, about 2 to 3% of people have an antibody. The other percent that we see with positive screens are a mixture of false positives that we have to work out later, and the fact that many of our patients have chronic illnesses and have been transfused, and so they have more transfusion exposure than the general population. And so, like I said, it takes at least an hour because we have to do at least one second round of testing to find out about what they have. It's also a good time in your pre-op planning to think about looking at their transfusion history or their antibody history. Have they had this testing done before? Do they have antibodies that you already know about? Patients who form one antibody tend to form more antibodies. So if they've been exposed anytime in between, either through pregnancy or transfusion, there's more likelihood that they may have additional antibodies, which will add time to this workup. The most common antibodies are actually pretty easy to match for, so they don't add tons of time, but we do see some antibodies around here that become very rare or relate to rare blood types, or that there are multiple antibodies. Yeah.
Can I use a question? The type and screen has to be done at this lab?
It has to be done in a Swedish lab, yes. And that has to do with lab regulations, that you're giving blood based on your own test results. But the Swedish system, excluding Edmonds, so Cherry Hill, First Hill, Issaquah, we're all in the same system. We share results. Okay? Feel free to ask any other questions that come along. One of the other things I wanted to draw some attention to is this confirmatory ABO and RH. One of the requirements for doing that electronic cross-match that I mentioned is that the patient has to have had their ABO and RH tested twice. And that's purely a safety measure. And because it's a safety measure, one of the critical aspects that maintains that safety is that those two tubes of blood are collected at different times. So either we tested them sometime in the past, like when they were here for another event, and now we get a new sample. So we know that the idea here is to prevent mislabeling based errors, right? So a common problem with this practice, which we can't avoid, this is an FDA requirement, is that especially when it's a new patient and we know they're going to need their basic type and screen drawn plus a confirmatory sample, nobody likes to go into the room and say to the patient, I have to draw your blood again, even though I was just here a little while ago. That's really uncomfortable. But I think if we turn that around and say to the patient, we're here for your safety to make sure no mistakes were made. The most common cause for a hemolytic transfusion reaction is exactly that, a mislabeled tube. And if you have one of those reactions, there's a 50% mortality. So we try to avoid that. So how do we place orders for this stuff? Um, and one of the things that's really, I think, is a little bit confusing in our Epic setup, and I think this is standard across a lot of EMRs, is that blood banks are parts of laboratories, and so all the orders that are placed for blood banks look like a laboratory test order, which means there's a portion of the order that actually looks like a laboratory test, and there's a priority, for instance, in there. And so it might say stat or routine, for instance, but that may be, that's for the lab drawing that specimen for the type and screen. It's different from the priority that you assign to the blood product that you want on the other end of this order package. And that can be a little bit confusing. So there's that. And then there is also the way our order sets work, which, let's see if I can jump ahead. So this is a little bit small, I see now on the screen, but this is our order set. If you pull it up, at the very top, there's a type and screen. And so if your patient does not have a current type and screen, that box is open, as you see here. So that's telling you before you order a product, you have to order a type and screen. So you need to check that off. And then we do have these, let's see if we can do, so it's kind of big, but this green section, prepare and transfuse. The benefit of this section is that you only have to fill in the details of the order one time. They will apply to both the prepare and the transfuse parts of the order. So when you come back here, what you have is, generally speaking, when placing blood orders, you have to prepare the product. So that's often called a cross-match order or prepare. And then you also have to give a transfuse order. The transfuse order goes to the nurse, the product order comes to the lab. So you've got different audiences for these different orders, and they each need to have bits of information about this transfusion, like how many units is it, when do you want to give it, things like that. If you use our green section, you only have to fill that information in once, and it auto-populates both. And if you use the red section, you're just ordering the product. And then the orange section is to say, remember that product I asked you to prepare a little while ago? This is how I want to give it. So we like the green section. It's great if you think you're definitely going to be transfusing, and that's the kind of transfusion practice we'd like to be fostering and moving toward anyway. It's really only ordering the blood when you need it. So in terms of getting through the orders, these orders have been in place now for 2 years. I do know there are people who are confused about it, and there are also people who haven't updated to using this particular order set because they may have had a previous version tucked away in their favorites. And the way Epic works is that sequesters certain changes from getting through. So there's a variation in order practice, and so I really strongly recommend that you use this. It's order set 2457. Let's see, what blood products are available? Everything's here on site, all your standard blood products, red blood cells, platelets, plasma, cryoprecipitate. It's all here. And that's part of the reason you don't need to order it in advance. So we've been on site now for coming up on 4 years. And so we do still have some people who don't seem very aware of that, and they think they're ordering products just to make sure they're coming from a distant blood bank to be here just in case we need it. Don't need to do that anymore. It's all here. It also speaks to the importance of that type and screen. If there's something rare that you need, we need to act on that in advance. We have platelets. Most of the platelets we end up with in inventory are apheresis platelets, which are also called single donor platelets. Those are exactly what they are. A donor comes in, gets connected to an apheresis machine, and only their platelets are collected. No other blood comes out of them, as opposed to a whole blood donor where their whole blood comes out and we separate it into components. The amount of platelets from one of those collections, a whole blood collection, is not a sufficient dose. So we pool those together. So one pool of multiple whole blood platelets is equivalent in dose to an apheresis platelet, and we use them interchangeably. So you don't have to order them one way or the other.
Qualitatively, is there any difference between pooled and apheresis?
No. Plasma, just to point out to you, it's not a big deal because we also use these interchangeably. There's a variety of types of plasma that are based on how they're manufactured, when they're frozen, how many hours after the blood was collected, things like that. We also use those all interchangeably, but they might have different names on they definitely will have different names on the label if you happen to notice that at the bedside. So what do we do in acute blood loss? So massive hemorrhage is one story, and there's been a lot in the surgical and transfusion news in the last couple of years about having massive transfusion protocols. And this is the latest, greatest version of that, which is basically a 1-to-1 transfusion ratio in an attempt to recreate whole blood through transfusion component therapy, right? And so 6 red cells with 6 plasma, with 1 pool of platelets, which is roughly 6 platelets, and 1 pool of cryo, which is 5 cryo. So this is basically a 1-to-1 ratio across the board. And what we have here is that we have been piloting a massive transfusion protocol that began as a code hemorrhage. We're working on getting this built in Epic so that it can be an orderable. So the idea for all of this is that you do this empirically until you get some lab results to guide you in specific components that you might need. In general, our transfusion goals are to get the crit in the 24 to 28% range. In your area, typically we're looking for higher platelet counts. We want our INRs to be less than 1.9 roughly, and fibrinogen generally at 150 in a surgical case, 100 in a patient who's not generally bleeding as much as a massive transfusion protocol. Here, our massive transfusion protocols, we release a first portion of this within 3 minutes. 4 red cells, 2 plasmas, and a platelet are going to be ready for you within 3 minutes of the call. These are uncross-matched group O red blood cells unless we happen to have some cross-match to your patient already. And the idea here is it's a faucet on, faucet off plan. You call us and tell us to start, and we keep going. After this first 3 minutes, we're going to keep giving you blood products to maintain that balanced transfusion resuscitation until you tell us to stop. So we started this about 18 months ago, and we've had 32 cases to date, all here at Cherry Hill. And all of them are being reviewed by 2 physicians. So me from the transfusion perspective, and an intensivist anesthesiologist. Yeah.
Do you know how many are cardiac versus neuro?
Most of these are cardiac. They're mostly occurring in the cardiac ICU and the cardiac procedural areas. And that's really the department we chose to begin the pilot with. But by word of mouth, there are a lot of people working in these procedural areas. They know how to use this, and they're in fact using it at other sites too. So, yeah.
Kirsten, if you call a code hemorrhage or a massive transfusion, does that also get you a hematopathologist to guide you?
So what happens is the blood bank staff will call the physician on call for them. So yeah, the medical staff from transfusion service is going to get on the phone within a few minutes. Their first priority is to get you the blood. Second priority is to get you some more blood, more plasma thawing, because that's the rate limiting step. Plasma has to thaw, it's stored frozen, and it takes a little while. So they do all those things, and then they call us. So patient care first, letting us know second, and then we get involved depending on what we hear is going on, what we can find out is going on. We try not to get too much in your face when you're really busy. But yeah, we're following these cases. And in OB, it's really critical because we give even more fibrinogen. They go into DIC so fast. They need a lot. If you're having acute blood loss, but you're not quite at the point of a massive transfusion protocol, it's the same idea, is that you're going to do some mix of empiric immediate treatment with transfusion and following with result-based transfusion planning. What I do think is important to keep in mind is that even if you're ordering stat tests or stat blood products, that's a 1-hour turnaround time, right? And we get a lot of stat orders. We don't know which one is more stat than the other. And so really, if you need something fast from a blood bank, the best way to do that wherever you're working is to place a phone call or have somebody place one for you. Tell us what you need. Now, in our transfusion service, we've trained our staff very specifically. If they get that stat order, we've asked them to call you, if you're not the one calling us to begin with, and ask you what you need and when you need it. And on purpose to help guide you through what we can get you in that time frame. So for instance, if we're starting from scratch, we don't have a type and screen, and you say, I need red blood cells and I can wait an hour, well, we can do that type and screen and get you some cross-matched red cells. But if you say I need them in 5 minutes, you're going to get some O-neg red cells. So our staff is trying to help you understand what's going to come your way and meet your need. Yeah.
How about if you have a type-in screen, but not a cross-match, and you need it as soon as possible? What does that translate to?
So that goes back to that electronic cross-match. If your patient has no antibodies, it's just a matter of doing that barcoding and printing out the form and getting it to you. If you're in an OR, we typically will tube it, which is about a 2-minute transportation time. If we can, or if we need to, we'll walk it down to you. That probably takes longer in actuality to walk down to the OR, or you can send a runner. And if you're not in the OR, best if you send a runner. We will bring something to the bedside wherever you are if we have to, but frankly, that means our tech is not in the lab preparing blood products for you. They're walking them around, and it would be better for them to be in the lab. So better to send a runner.
So a typical spine case, if you're losing blood and you think you're going to need it, it should be, what, 10, 15 minutes?
Definitely within that time period, yes. Yeah, probably in the neighborhood of 5 to 10. Okay, so what about anticoagulated patients? Like I said, I think this is such a huge area right now, particularly with all the direct oral anticoagulants and their new reversal agents. One of them just got approved a few weeks ago. I really think the pharmacy group is better to talk about this in an extensive way. But some of the big things that we see, aside from that, is we still see a lot of patients on warfarin. And we used to correct that a lot with plasma, and one of the big problems with that is it takes a lot of plasma to make a reversal. We get our patients volume overloaded. It's pretty slow, so we're delaying their time to the OR potentially when they need to get there sooner. So now we also have fewer concerns these days with the current formulations of vitamin K with reactions than there used to be. So vitamin K works well, and PCC, which is a 4-factor prothrombin complex and is available through pharmacy. So this combination of treatments a lot more focused on the coagulation defect that's caused by warfarin. It's low volume, it's fast, and we don't risk transfusion reactions. So this is the better approach, particularly in neurosurgery when you're up against time and volume issues. So I think this is the latest recommendation in that setting. So consent, just to bounce along to that, the main thing here is that it's patient-centered, right? Patients want to know if they're being transfused and what can they expect from a transfusion. So the changes that we've been through in the past few months, the difficult part really has been its relationship to other updates on the surgical consent form. But if you think about transfusion consent in particular, what's really different is that we have a separate form for it. It has the information patients want to know that are on the form, which helps you because some of those details you might not know, like still the most common question from patients is, what's my risk of getting AIDS from a transfusion, right? So just in case you don't have that number on the top of your head, it's on this piece of paper. So it's a good reference for you too. And then the main thing is that both physician and patient need to sign on this separate form. So risks, benefits, and alternatives are the critical elements of consent. They're here. What we don't have on our consent form is this really, the sub bullet here about post-op infection, increased length of stay, and immunomodulation. There's growing literature about all of these. Many of the studies that have been done are focused in one healthcare arena or another. There's a lot, for instance, in orthopedic surgery and cardiac surgery. So we have the inkling that these apply across the board. We also know that patients who get transfused do have, in general, longer lengths of stay and more post-op complications. So these are real, but we don't have them on our consent form because they're very difficult to quantitate. And as I said, the literature is often focused in specific patient populations. So we didn't feel like it was, they were really ready for prime time from a patient perspective, but for you to keep in mind, and if your patient asks you, they're real considerations. And then this is really important, is in our patients with hematologic malignancy, we want them to get irradiated blood components. That prevents transfusion-associated graft versus host disease. So transfusion is a type of transplant. It comes with a lot of lymphocytes, And in a patient who can't recognize those lymphocytes as foreign, they may well invade the bone marrow and take over. And transfusion-associated graft versus host disease is about a 98% fatality rate. So definitely another thing we like to avoid. And so we cast the net pretty wide. Anybody with a hematologic malignancy, even MDS, because they're on the verge of a malignancy definitionally.
So
For these patients.
I've seen in ethics, some of them have flags on their chart that come up as soon as you open the record, and others don't. Why is that not universal?
So what do you mean by a flag?
So there are certain
Patients with malignancies that will get an alert pop up that it's a hard stop that says this is this patient is immunosuppressed from whatever, and if ordering blood, I think it gets put in somewhere in the Cancer Institute, but there are flags on certain patients, but it's not universal, and
Right.
obviously very helpful to get that as soon as you get a patient, oh, I know I need to order irradiated units.
So let me look into that, because we do not have a hard stop in the blood ordering process. So I know that's true at some other places. They have a irradiated and non-irradiated blood ordering pathway, and once a patient's committed to the irradiated pathway, there is a hard stop. We've not been able to engineer that just yet. We do have our techs look for locations of diagnoses. Most of them review the problem list, but they're techs, right? They're not medical staff, and it's not their responsibility. So we offer them the opportunity, and they do check. And if they see something where it's not ordered and they think it should be, they generally check with me. And there are some patients, if they're being treated in SCI, for instance, we just add irradiation to the record as a safety net issue. And you may or may not have a flag or a previous order that was placed correctly, but once we know about that, we put them into the internal laboratory system as needing irradiated. So we try also to provide a safety net there to catch all of these patients. But we do see, even from SCI and patients with leukemia, from time to time, people forget to put irradiation on the order. And, if we didn't already know that they needed it, that could be a disaster. So we're really trying to have a lot of ways to assure safety around this. And we treat a lot of these patients, and a fair number of them come to your department for a variety of procedures. And so if you're not the primary service who's been treating their lymphoma, for instance, it's pretty easy to not be in sync with that, thinking you're going to do a surgery. And so that's why I'm putting it out here today. So just keep your awareness up if you're bringing these patients in for surgery. So that was the list. I can't see the time on here, so how did we do?
Great.
Okay, any other questions?
I had a question about the reversal of low knocks.
Mm-hmm.
So that sometimes we have that situation where someone comes in with a lung people or something and they're taken straight to the OR. There's always this question of what do we give them? We give them protamine, and someone says let's throw some FFP at them, and someone will say let's throw something else, and no one really
Right.
knows.
So there's no blood product that reverses the effect of heparin. Plasma will not do it. The protamine is the answer.
But it doesn't completely reverse the low knocks.
For protamine, probably not, but plasma's not going to help either.
Right.
So yeah, there's no blood product that's going to touch the effect of a heparin drug.
And is there any point in doing a factor 10 or anything after you've given that protamine? Is there any way of knowing whether it's the blood knocks is reversed?
You probably don't have time in that situation to get that test result, would be my guess.
Would it be useful?
Maybe, maybe not. I'm not sure that I would consider it a guiding force. So I guess I'm saying I don't think it's that useful in the moment. Not an absolute answer.
Do we know then how much it will reverse for Lovenox, low molecular weight with protamine?
I don't happen to have that formula off the top of my head. This is why you need the pharmacist. They probably could answer that really quickly, but I don't know. I'm sorry.
At least downstairs, we typically give a pretty modern dose of protamine. The heart guys will give like 100 milligrams without batting an eyelid. We typically give a lot less. Usually give like 50 or something like that.
And then you go to the OR. If you have a patient that's on Lovenox and needs surgery, you just give them protamine and go.
But we have to do that the other week.
Yeah.
But I mean, it was awful. They're putting an IV lines in the blood coming out of the IV.
Wow. What kind of a PTT would a patient have to bleed, that badly?
Right,
It's
I don't know.
it's got a short half-life too.
It was like cauterizing Gatorade.
Oh my gosh.
Same question for antiplatelet application.
So antiplatelet drugs, generally, we talk about platelet transfusion in terms of counts, but function is clearly important. If you don't have functional platelets, you're a lot more likely to need a platelet transfusion. One of the things I do see is we see orders for multiple units of platelets right up front, and I think that that's probably an overreaction. A patient who is not a cancer patient on chemotherapy typically will get a really good bump out of a platelet transfusion. So just had this issue the other day, get this several times a week, right? People see, oh, my patient's platelet count is 30 and I want it to be 50. So they order 2 or 3 units of platelets and one will get them there. So you'll see in most patients with that intact transfusion response, if they're not massively hemorrhaging, you're probably going to get a bump of around 30,000 out of a single platelet transfusion. So it's a pretty substantial bump.
For more of a patient who's on aspirin and Plavix, typically, we want to do it on one short interval where they're
Right.
protected, so it's good to.
So typically, and this is when they've not stopped their drugs in advance,
Right.
1 to 2 units of platelets will definitely get you there safely, I think.
So,
Yeah.
so 2 units would mean, even though they're on aspirin and Plavix, fully therapeutic on Plavix, we give them 2 units, then they're going to be clotting.
Yeah, they should, because they're going to get a bump. They're going to get a high number of active platelets, right? And if you're no longer giving the drug, it's not going to be affecting those platelets, and then you can monitor based on count and function, like how is the bleeding doing as you
And the timeline,
get some hours out.
Timeline, you expect that those transfused platelets to be active is
Immediately.
platelets.
Immediately, yeah, for the life of the platelets,
And
yeah.
then if you give more drug, those newly transfused platelets,
They're going to get it right,
It's self-circulating.
Right.
yeah.
Kirsten, what is the expected life of platelets off the shelf versus endogenous platelets?
Even endogenous platelets have a pretty short
Well, 7
life.
7 days for endogenous, but I was
Yeah.
told that it was less for transfused platelets.
Yeah, they're not going to live quite as long, but one of the more critical things is that we can only keep them on the shelf for 5 to 7 days, right? So from the day they're collected, they've got a 5-day out date, and if we test them and find them to be negative for bacteria, we can now extend their shelf life to 7 days, but that's it. So you're within the lifespan of the
If
platelet.
you're transfusing a day 6 pack of platelets, you're still probably good for a couple of days.
Yeah, exactly.
So you can't freeze them.
No, we're actually starting to look at some studies to do that, but basically platelets are stored at room temperature, which is why bacterial contamination is such a big concern. They have to be agitated. I mean, they're a really delicate, finicky blood product, and 5 days. And the first day and a half to 2 days is spent in getting tested and transported from the collection facility to us. So, yeah.
Just for my own knowledge, PCC, what is the cost of dose PCC?
Good question. It's rather expensive. It's by unit, I think, and I don't know the exact answer of that, and it changes a lot, but it's thousands of dollars.
It's like 10 or 20 grand.
Yeah, I heard it's
Yeah.
10. That was a while ago.
Yeah, exactly, and they shift around a little bit. Typically,
Get it on Amazon.
the clotting factors typically run around $1,000 a unit.
And then you said like, Xarelto and some of those drugs. I know in Europe there's those 10A reversal agents.
Yeah.
Do you have those?
We do have some reversal agents. There were, I think, 2 on the market before recently, and then this brand new one, and they're drug-specific reversal agents, and I can't rattle them off for you.
Yeah, they're approved.
Do we have that?
Yeah.
So I think those recently we called up and they're like, oh yeah, it's on the market, but we don't have it.
Oh,
Yeah.
really?
Yeah.
That was a while ago when we had that, but it was kind of
Like I said, we're going to bring pharmacy back
Yeah,
to talk
definitely
about
get-
those so we can grill them about pricing and stuff.
Yeah, because I know as of last year they weren't readily available all around the U.S. So I just didn't know if that was
Yeah.
common now.
Yeah, they're definitely available. Also expensive, and the FDA is trying to push them through relatively quickly because these drugs are getting used so much.
Kirsten, I have two questions. One is, do we have elastography available as far as evaluation of ability or flow clot?
Right, so thromboelastography or TEG, we do have on site here. It's used mainly in the cardiac surgery ORs, but I'm sure it's available to you if if we work it out as a system, like to make sure the staffing is there and coordinating case timing, things like that is in place. We also have it at First Hill where it has lived in the liver transplant OR area, and we are right now working on implementation of another instrument in the surgical ICU at First Hill in order to follow the liver transplant patients post-op and pre-op. So we're looking at them with one method all the way through their care episode. And then we're going to start expanding it into these other heavy bleeding populations like the OB hemorrhage and things like that, other patients who are in that surgical ICU.
So who's the point of contact if we want a TEG study at Cherry Hill?
The point of contact is both me and your lab manager, Shad Nguesso. He also has a TEG in the lab here, I believe, where, again, they scheduled patients who are having like hypercoagulable workups. They come over here and get their blood drawn for it. So, we're really evaluating it because it's useful. Do you use it much now for your cases?
No, not here, but where I came from was a major trauma center, and it had basically supplanted all other coagulopathy testing.
So it's really interesting to me because across the board, the response to TEG is great, that everybody feels like they decrease their transfusion requirements or alter their adjust their transfusion approach based on TEG because it's more of a whole blood assay. You can see different angles and amplitudes that suggest specific functional defects. But when you look at it in the literature in comparison to so-called standard lab tests, it's really not telling you different information. I think it's actually suggests to me that we're very responsive to seeing a cute little graph, and we have this visceral response, and we're like, oh wow, that angle's low, I know I should give some platelets as opposed to some plasma, as opposed to us getting back like a PT result and a PTT result and platelets. Are these very functional platelets? Are they not very functional platelets? And trying to gauge our transfusion responses, and so we tend to throw more of the kitchen sink at our standard lab results than that nice graph that we can see.
And my other question is, can you comment on post-operatively, once the patient's stable but still anemic, how, 1 unit versus 2 unit transfusions for people who are anemic post-operatively?
Sure. So the question is how anemic, for one thing, right? So patients may drop a lot in their hematocrit or hemoglobin, and we don't really need to replace all of that. And now we have a pretty large body of literature telling us that most patients, if they're no longer actively bleeding, even if they've dropped a fair amount, they don't need to be pumped up to a crit of 30. Somewhere in the mid-20s looks like the right number for most people. That's why for the transfusion trigger is 21%, right, across the board, with the potential exception of people who are having acute coronary ischemia, in which case it's more like 26 to 28% where we want to keep them. So we don't need to move them very far. And if we're starting around 20 or 21%, 1 unit is going to get them where we want them to be. So the standard recommendation now is 1 unit of red cells in a stable, not actively bleeding patient, and reassess them. And we should be using symptoms a lot more than lab results, right? So is your patient really short of breath or tachycardic, something along those lines? What we see, just anecdotally, is vital signs don't seem to change a lot in response to transfusion, and report of fatigue, particularly in a post-op patient where most of them have that fatigued feeling. That's not a good indicator of needing a transfusion. Good questions. Thank you.
Thank you.